Hi all, I'm Dr. Neema Bhat, Senior Consultant Hematologist and Pediatric Oncologist in Apollo Hospitals, Bangalore. Let's talk about a topic which we don't address as much as pediatric oncologists because usually these patients go through orthopedicians. So as pediatric oncologists or as pediatricians or maybe even as orthopedicians, you might have come across these patients without realizing what is the next best step or where exactly the treatment journey should be started. So these are bone tumors, specifically talking about osteosarcoma or Ewing sarcoma, which are very common bone tumors seen in children and young adults. So osteosarcoma, as most of us know, is found in most of the long bones and can metastasize or move to the lungs or different areas of the body and have to be treated at the earliest so that metastasis or them spreading to other parts of the body can be avoided. Pediatric osteosarcoma is a difficult diagnosis to treat because number one, it can be very chemorefractory, may not really respond to chemotherapy. Not all of the tumors will respond to chemotherapy. Number two, if it already presents in a metastatic state, then surgery does not really have an option or does not really have a role, and the only treatment option available is chemotherapy. Most of these tumors tend to be not radiosensitive or they don't really respond to radiation therapy. What is the role of a pediatric oncologist in osteosarcoma? I would say the first person should enter when a patient is diagnosed with osteosarcoma is a pediatric oncologist. Now there are different, as I said, there are different ways to handle pediatric osteosarcoma. Sometimes when the patient walks into an orthopedician's clinic or a surgeon's clinic, the first instinct of the surgeon is to remove the tumor out, right? So as fast as possible, they want to make sure that the tumor is out of the patient's body. But let's tackle this in a little smarter way. So we are talking about a child or a young adult. We want them to have a good quality of life. We want them to have well-functioning limbs, arms, legs, whichever part the tumor is involving. What is the best way to preserve most normal tissue at the same time trying to eradicate the cancer? So there is something called neoadjuvant chemotherapy. So basically before you even plan to remove the tumor out, you give chemotherapy so that you can shrink the tumor to as much of an extent as possible. We see as good response as 80 to 90% shrinkage in the size of the tumor. How that helps, especially in a child, is if, say, a tumor is involving a large part of the bone and a surgeon takes it up for surgery, the child ends up losing the limb. Basically a hand or a leg is completely gone and the child has to live with that handicap for the rest of their life. However, when we talk about chemotherapy in the neoadjuvant phase, followed by what we call limb salvage surgery, we are talking about shrinking the tumor to its maximum extent, including separating the tumor from whatever vital nerves and arteries or blood vessels it may be involving, so that in the near future, we can plan for an important procedure called limb salvage. So that's nothing but trying to preserve the limb of the patient. It could be, again, a hand or a leg. Most often it is the leg, where we try to make sure that the patient has their own limb available in the future to use a prosthesis. If you see a patient, especially a young child, who has undergone chemotherapy followed by limb salvage surgery, their adaptability to a prosthesis to get a better quality of life is always much better compared to a child who has undergone upfront surgery, basically limb amputation or removal, followed by chemotherapy. Their adaptability to a prosthesis, their range of movements, their mobility and their quality of life is usually far lesser or much more compromised compared to a patient who's undergone a limb salvage surgery. Now, I was trained in the US where we used to perform, our orthopedicians used to perform high-end procedures called Van Ness rotation plasty, where they would try to convert the ankle of the patient into the patient's knee by flipping the ankle across so that the limb is still preserved and the mobility of the patient's joint is still preserved at the knee, giving them a lot of range of movements, even if it means using a prosthesis. Where I come in as a pediatric oncologist is making sure that the right chemotherapy schedule is designed. The patient is able to receive high-dose chemotherapy, including cisplatin, doxorubicin, methotrexate, which is not deliverable in most of the centers because of the support system that's required. So, for example, high-dose methotrexate is a high-dose chemotherapy that's delivered after a lot of planning and monitoring, post which drug levels have to be monitored, patient's urine output, urine pH, a lot of important but small parameters have to be given the right attention to so that they're able to tolerate the side effects of the chemotherapy and at the same time get the benefit. So if the patients are able to undergo a few cycles of these neoadjuvant chemo followed by salvage limb, it gives them a limb salvage surgery, it gives them a much better outcome and a much better quality quality of life going forward. So let's try as a team of pediatric oncologists, pediatricians, orthopedicians to try to give these children the best outcome and quality of life possible, while of course keeping the focus on keeping them alive and safe and away from these tumors. If you have any doubts about osteosarcomas or Ewing sarcoma and the role of chemotherapy, neoadjuvant chemo and limb salvage surgery, kindly reach out to me at Apollo Hospitals, Bangalore. Thank you.